is a third-generation EGFR inhibitor, such as osimertinib Tagrisso, possible after progression on erlotinib in someone who's T790M negative on both circulating tumor DNA and tissue biopsy, and who also had been on and progressed through chemotherapy now. What's your take on the utility? Because it has been looked at, and I think it's in the realm of you can potentially do it. There's a difference between whether you can write for it and whether it'll be covered, and then what is the anticipated benefit that you would anticipate, Justin?
Yeah, so the first question I would ask is, where is the site of progression? If the progression was in the brain, for example, that would be a scenario where I would consider it, because we know that osimertinib had much better CNS penetration, and the disease in the brain may simply reflect more of we call it pharmacokinetic issue, that is inadequate drug levels of the prior therapies. Outside of that situation, it wouldn't be my first choice. Jack was alluding to, this was studied in some of the early trials of osimertinib, and the response rate, if it was tumor lacked T790M, was around 20%. That's one of the numbers that I keep in my head. I think for me, it would be far more appealing to think about some of these newer strategies. But I'd also want to know, even if it's not T790M, what actually is causing the resistance. So we know that there is actually good data for targeting MET amplification. There is data showing combination therapy. So that would be, one strategy. So trying to understand if there's MET amplification. If not, I think the amivantamab osimertinib data on a clinical trials is very appealing. I think the HER3 antibody conjugate is also very promising. And so in my own practice, looking at trials in that space.
And I agree. I think you make a great point that one first issue to step back to is, if this is brain primarily or brain only, there are data that show that those are often less likely to have the resistance mutations carried in the rest of the body, because it may just be an issue of not getting through the fence. And so, having osimertinib may be particularly valuable there, or if it's very limited progression, local therapy could be helpful. Unfortunately, what we've generally seen, what my interpretation of it is, that if you get any response, it's very short-lived, and it's just kind of the brief reintroduction of any EGFR inhibitor. You'll get a couple of weeks of benefit before you get a very rapid takeover of the resistant clone. So not as promising as some other ones.